There was a question about the exams. Oh, hey, Stephanie. I think we got it done. Stephanie's your other ExamSoft Exemplify person. So the exam in this class, I'm done writing it. It's 50 questions, a combination of multiple choice. There is one drag and drop. Remember on the mock quiz, you could drag and drop a marker. So I do have a drag and drop. There's some select all that apply, some drop down menus, select the best statement or select the best thing to finish the statement. I don't have any short answer fill in the blank on your first exam. I did have people asking me for like study guide questions. If you look on Canvas on the week or in the module where the exam is due, and then click on the information for that module, you'll see some study guide questions. Actually, let's do that now. Go ahead and take a look at that now. Just real quick, go to your Canvas page. You guys are brave doing that on your phone. Yes. All right. You are welcome. Okay. Now, let's finish up on our ethics stuff. Do you guys remember where we were, what topic we were on Wednesday? We were working on Hipaa. So are you guys ready? I want you to watch this video, and I want you to tell me what you would do. Let's see if I can get the right amount of sound. Oh, hang on. Pause. I'll fix it. Thank you, Carrie. Thank you, Stephanie. Okay, I hope this doesn't blast your ears. Back up. Okay, we'll try again. It's really hard to hear. I'm sorry. I have the volume up as high as I can go. What did the person in the white lab coat just say? Oh, she goes to my church, you know. So should I back it up? Did you hear all the protected health information that was shared? Okay, I'm seeing some head nodding. Somebody wants me to back this up. I can turn up the volume just a titch more. So let me do that. Now that I know I'm not going to hurt anybody's tympanic membranes. Are you watching the nurse's face on the right? Okay, keep watching.
Don't worry, and I can always check her history on the chart. Gosh, Bernia, this is Jackie. I'm feeling okay.
Okay, what'd you see? Why the giggles? Yeah, the door's wide open, so I just walked on in. And then so this is Amanda. She's a lovely graduate. You can tell this is some research I used to do at the University of Portland about moral distress and ethical dilemmas. So she signed a consent form to let me show this for educational purposes. She's working in an ICU right now, has a very great career. But as a student, how hard is it when somebody walks in, they just start rambling off all these questions, and then you find out that they really don't have a right to know, and then look at this poor little face. Oops, why aren't you playing?
Are you? And I work here. Okay. Don't worry. And I always check her history on the charts. Gosh, Bernia, this is Jackie.
So what would you do? That's the question. So do you all agree that the facial grimace, her body posture is showing that she's uncomfortable? Okay, so she is a senior by the time we did this research study. So she's already had her class in communication, ethics. This is a senior capstone simulation. What would you do? Yes.
I mean, based on her body language and everything, she clearly is not comfortable addressing the situation in the moment. So I think it would be appropriate at that point to go to a supervisor or something. She obviously has to disclose that she accidentally disclosed information.
Mm-hmm.
And then I would report for sure that this lady is accessing patient charts and just popping into rooms.
Yeah. Yeah. So some choices that you have in this ethical situation, because remember in the Markowitz Center framework for ethical decision making, we have to identify that there is an ethical problem to begin with. Did she do that? Yeah. So she has to think about choices, and some of the choices are confront this person right now and say, this is protected health information, you don't have a right to know this. Or, like, are you involved in this patient's care? I think she's already established that this person's not involved in the patient's care, that she's a church member and the door was wide open, so she just walked right on in, right? She could also educate this person and say, hey, I know the door was open, but really, in this setting, you're breaking that's a Hipaa violation, which is reportable. If you are a student nurse, yeah, you're right, or a licensed nurse, you're going to have to fill out an incident report. What did you call them? Somebody else called them something else. Confidential occurrence report, something like that. Anytime there's a healthcare worker error, we're supposed to fill out these reports. And then who are the key players? Who's at the center of all of this that we're trying to protect? And isn't she adorable? This is Vernia. Yeah, the patient has a stake in this. The student has a stake in this. This person does. The hospital attorneys do. I mean, there's a lot of different people. So, have we talked about all the choices? Is there one I'm forgetting?
Well, I would also confront her in that, like, it's not her place to, share the information with other people. Like, that kind of struck me.
Oh, yeah, she implied that the people
Yeah.
at church have been wondering what's going on with her because she
And
hasn't
so-
been coming to
And
church.
so she's going to tell them, and that's
Right.
not okay.
Yeah, so let her know that she shouldn't share that information forward. Go ahead, Erin.
I just have a question about a scenario. So right when the doctor walked in, she started, she asked one question and the nurse just started, sharing all the information.
Yeah.
I assumed it was the doctor.
Right.
I'm not sure it was
Right. The gist of all of this is, if you don't know who the person is that you're telling information to and what their role is in this situation, you just don't tell anything. So maybe one of the choices is to preemptively prevent the disclosure by saying, oh, hi, you just came right on into the room.
Yeah. Who are you?
Can you tell me your role here? Yeah, maybe they're a lab tech. Maybe they're PT, OT, physician. I don't know. Yeah, really good point. Yeah.
I think that my instinct to react to this would be, as soon as I realize that that other person is, sharing all this information, ask them, hey, can I speak to you outside the room? Because I think that, in front of a patient that's, conscious and, aware of what's going on, they might not feel, as, their information is being protected.
Yeah, so putting the patient back at the center of everything that we do. How would a patient feel, like you said, if they're conscious, how would they feel or how would they perceive care if you're sharing all your private information with this person who just walked in the room? In the context of this scenario, this is the patient's heart rate. This is the patient's oxygen saturation. And so in this situation, we wouldn't want to leave the room if this is new. But so it's, again, isn't nursing very contextual? We do have a lot of choices based on what's happening. But asking this person to tell us who they are and what's their role.
Even just pulling them to the side where you're not like speaking over the patient.
Yeah.
So I feel like it's just really trust. Like you confide in your doctor, you confide in your nurse that they're gonna hold their information like valuable, and it just breaks all the trust. Like I feel like you don't hold them to as high of a standard as you do.
So what Skylar's saying over here, and the reason why I keep moving around is so that when you guys listen back, maybe you can hear the conversation. What she's saying over here is that the patient's trust in the healthcare provider as a trusted, I use the word trust twice, sorry, as a trusted professional has now been deteriorated. Yeah. Well, let me finish playing this and you can see how she handled this. How about we do that?
Oh, she's really bad, isn't she? Gosh, well, you don't have to tell me anything. I'll just
Yeah, I'm not looking at you.
Well, thank you. I won't say anything.
Yeah, she's really sick, so maybe not right now.
Okay, all right.
Thank you.
Thank you. All right.
Yeah, that'd be awesome. Thank you.
So ultimately, I don't know if you could hear that. Plus, when I was trying to do the playback, the lips didn't match the sound coming out. Ultimately, she said, well, you can only look it up in the chart if you have a right to, or if you have a need to. So that's the basis of HIPAA laws, is that only people with a need to know the information should hear it. Now I'm going to give you a quick scenario here, and you tell me if I'm breaking HIPAA laws. Brian is my patient, sitting in the waiting room at the emergency department. I'm the nurse. You're up next. Finally, you've been waiting 4.5 hours. I'm so sorry. Brian, you want to come in? And he follows me to the ER, to the back, to be treated. Did I break HIPAA right there? No. A first name is not protected health information.
His full name would be okay.
And how else would I get Brian out of the waiting room? Brian, you know that kidney stone that's killing you? Why don't you come with me and we'll go check it out? Like, how else am I supposed to do that? Or person with a kidney stone, person with a kidney stone. Now I'm being silly now just to make a point, right? Right? So first names are okay. I'll give you another scenario. I have a patient in a wheelchair. I'm in an elevator with other people. The patient's going home, and I say to the patient, I don't know. I hope everything turns out great for you, and please call us if something happens and you need to speak with us.
More specific of what something's.
Right. I didn't release any protected health information. Okay.
If you said if the kidney stone bugs me again,
Yeah.
bugs you again, then you'd be releasing their information.
One more scenario. Anybody ever been in an emergency room? Yeah, they have a lot of bays, patient rooms. Some of them are private with a wall, with walls and a glass door or whatever. But a lot of them, especially now, just have a curtain in between patient beds. So I am over here. Remind me of your name.
Genevieve.
Genevieve. I'm over here talking with Genevieve, and all I'm saying is, yep, you're right. Those white blood cells are really high. Let's say that she has me looking at the electronic health record to verify something. Those white blood cells are really high, and check this out, the lymphocytes on the differential are also really high. Now the person on the other side of the curtain can hear all that, but how else am I supposed to have this conversation with Genevieve in that setting? So I did release some protected health information about lab results, but I didn't release them within the context that would help that person on the other side of the curtain identify those lab results with that person. Does that make sense?
Mm-hmm.
So that's going to happen. But what if I'm over here with Genevieve going, yep, you're right, Loretta Crouchide, born in 1965. Looks like she's got a cyst growing on that ovary, and that looks really bad. I mean, that's ridiculous, right? But yeah, right?
That's just like so obnoxious.
So yeah, just be thinking about those kinds of things when you're thinking about HIPAA. All the rules and regulations are spelled out in your student handbook. Oh, I don't know what that was about. Okay, so now that I've given those scenarios, let's test your understanding. Which of these are HIPAA violations? Select all that apply. And I can see that I kind of messed this up here. I made this too small. And now I don't know how to make it bigger. Crud. Maybe if I turn it sideways? Nope, that won't help. So let's just start with the first one. Patient overhears the nurse talking to another nurse on the other side of the curtain. And they're discussing how to calculate a correct IV drip rate. That's no violation. We didn't release any protected health information. Everybody agree? Okay. A nurse calls a patient by their first name when they greet the patient in the waiting room. No violation. But if I said their name and their date of birth and their diagnosis, that would be bad. Nurse gives chlamydia lab result to a patient's spouse over the phone without the patient's permission. Yeah. What's chlamydia? Sexually transmitted infection. Yep. And it doesn't really matter like what the lab result is. We don't give lab results over to the phone to spouses without the patient's permission. Okay. A nurse tells another nurse who is not involved in the patient's care that a patient was just diagnosed with COVID. That's a violation. If that other nurse is not involved in the patient's care, they have no need to know. And frankly, that's just kind of gossip. Certified nursing assistant is transporting a patient in a wheelchair to the X-ray department. And the CNA says to the patient, I hope your procedure goes well. Not a violation. Not a violation. That's just being kind, right? Something very similar to this is going to show up on a computer screen in a couple Wednesdays. So, hint, hint. Oh, I don't know why that's doing that. So I told you that that video was from a research study I did. We were trying to figure out how nursing students respond to microethical dilemmas. If anybody's interested in reading that study, it's very interesting. And here were the findings. There are a variety of ways that people can communicate. You guys all had a communication class, right? Yeah. So there are a variety of ways that people can communicate to get the job done. Sometimes you do have to be competitive. Competing is typically not the best communication strategy because it creates a I win, you lose scenario. And most people don't work well as colleagues for an extended period of time if I'm always competing, right? But will there ever be a time in your career where you're going to have to compete to keep a patient safe? Yes. Yeah, there will be. I had a doctor on the phone at 3 a.m. with a patient who was bleeding out, and he told me to start a medication to make her contract. And I'm like, I cannot start that medication. That's unsafe. And he said, so you playing doctor now? I said, no, I'm playing patient advocate, and I'm a nurse, and I'm the ones with eyes on the patient, and she's bleeding a lot. And if I start Pitocin and make her contract, she'll bleed more. She was abrupting, which means the placenta is tearing away from the wall of the uterus, and the baby wasn't born yet. He ended up coming in. He drove in. We took her into the OR and saved that baby's life. The placenta was half ripped off. So that's a scenario of competing. I was assertive and uncooperative, power-oriented. It is easier to do over the phone.
Yeah.
No, I am not going to start that medication. That is unsafe.
And then when they show up, you're like,
Yeah, he apologized and offered to buy me coffee in the morning, so it's fine. It's fine. But we didn't have Pete's, so. Okay, accommodating is typically what you'll see happen. You're being unassertive and but cooperative. Did you see Amanda being a little bit unassertive, just in her body posture and tone of voice? She didn't know who that person was, and she was trying to establish relationships, so she wasn't being aggressive. She was like, well, if you have a need to know, you can look in the chart. So that's unassertive, but still cooperative. What she's trying to do is satisfy her own concerns and the concern of another. Avoiding is both unassertive and uncooperative. And there will be times when you'll need to avoid. Some patients, like, what's the first sign of low oxygen to the brain? Confusion. Confusion is the first sign of low oxygen to the brain. Yes? A brain that doesn't have enough oxygen is confused. And then as the oxygen becomes even more depleted, people start to get aggressive. And so you may have a time when you're walking into the patient's room and they're standing at the side of the bed, and as you approach them, they're just aggressive and they want to swing or punch at you. We do have to keep the patient safe, but that's a really good time to avoid being aggressive and assertive. Sometimes you have to use avoiding. You'll have to decide when that is. Was avoiding a good choice in the video we watched? No, you don't want to avoid them, because then that other person will just keep breaking Hipaa violations. Collaborating is probably the best one if you can get there. It's both assertive and cooperative. You work with the other person to find a solution that satisfies the needs of everybody. And that's why the Markkula Center ethical decision-making framework asks you to consider who are all the stakeholders, who has a stake in this. Because collaborating would include the patient as a stakeholder who would have a stake in how this turns out. Compromising is the middle ground between competing and accommodating. And then we also had some students who didn't even notice the dilemma. Like, we did this with a variety of students. They didn't know what was going to happen in the simulation. They just liked me, and so they signed up for my study. And so I think that's why they signed up. Why else would somebody do that? And so they didn't know what was going to happen. But there were a certain percentage of students who, when the nurse walked in the room and just started doing something, or whoever that person was, doctor, OT, PT, they just turned their back on them and got themselves busy doing charting or something else. That's actually a really sad thing to see happen, because that's called abdicating your responsibilities as a nurse. When you're the nurse in the patient care room, you're responsible for the whole environment. So what percent of students do you think didn't notice the dilemma? Percent. Mm-hmm.
10, 25.
Not bad. 15. 15% didn't notice the dilemma. And these are seniors on the cusp of graduation. So we had lovely chats. I mean, this wasn't worth a grade or anything. So it was just a really nice exploratory study. The thing that seniors were more often to do, 35% was the biggest number, they were more often to use compromising, which is great. Yeah. Anyway, I think it's always interesting to blend in evidence-based practice and show you guys what your learning peers are doing.
If the
if the patient starts bringing up their own information in a public space, do we have any responsibility to like diffuse that, or?
Okay, so talk about context. So the question was, what if you're in a public space and the patient starts just divulging all of their things, right? Sometimes patients are doing that because they're under the influence of a medication that is making them not think straight. Sometimes they're hypoxic. Sometimes they have a long-standing mental health disease. Yes. In those situations, we just kind of whisper in their ear, you know what, let's just keep that between you and I. Now, sometimes you can't get them to stop talking because some people in like a manic episode, they're just brrr. So you do your best. Yeah. Anything else? Yes.
So like in the case of, like, let's say there are two Bryans, like patients at the same time, you call them up. And
Oh,
is that
yeah.
why they ask, like, oh, when's your date of birth? But like in that situation, if there's like two that like stand up right away and not just one comes to you?
So I haven't had that happen, but my son-in-law who works in the ER has had that happen. I asked him, I'm like, how do you get patients out of the waiting room? Because he does triage over at St. V's. They do use first name first, and if like 3 people stand up to respond to that, he knows who he's really looking for based on why they're there.
Okay.
Yeah, so you can kind of take a look at the person and try to figure it out. Like somebody coming in with a kidney stone, they're going to be standing up going like this. Or somebody with a cut that needs stitches, they're going to have, the triage nurse would have put some gauze on there. If you can't tell when they both come forward, then you just quietly say, whose last name is this? Yeah. Sound good? Yeah. Okay. Anything else? Okay, that finishes our ethics stuff.
Can you go back for a second?
Sure. Health promotion and self-care. Ready to switch gears?
Yeah.
This is a longer class. Do you guys need a 4-minute bathroom break or stretch break? Okay, let's do that. Health promotion. Health promotion is defined as the process of enabling people to increase adherence and control to improve their health. Yeah? So the idea about health promotion is that we can actually sit down and visit with people, figure out what their health goals are, or, you know, if they're a kid, sit down with a guardian or parent and figure out what strategies can we implement to improve health. And also what strategies can we implement so they can sustain adherence. Like they can actually comply with what they need to do to improve health. What do you guys know about diabetes type 2? Is that the juvenile onset or the adult onset? It's the adult onset. And the way that people, we're going to go a whole lot into diabetes type 1 and type 2 in the patho class, but just for now to make the case about adherence and control. The thing about type 2 diabetes is that it is caused because the insulin receptors on cells become resistant to insulin. If I were to draw a picture about this really quick, and I mean really quick, let's say here's a cell, and there's more than one insulin protein receptor on a cell surface. I'm just drawing one for the purpose of discussion. This receptor is designed to receive the insulin hormone. Bless you. And when everything is healthy and working, this insulin hormone attaches to this insulin receptor, and then that signals to the inside of the cell, and then the inside of the cell signals to GLUT receptors that open up. And then what happens is, how do I want to do this? I'll do it this way. And then what happens is glucose molecules can come on into the cell. So that's how that works. Do we need to recap that? Okay. This blue circle here is a cell. This black shape is an insulin receptor. It's a protein insulin receptor. And it's designed so that the hormone insulin, which I could make a different color to try to make this better for people. I don't know, what color do we like for insulin? Let's make it orange. Insulin syringes are orange, so we'll make it orange. Okay. It's designed so that insulin will dock with the insulin receptor. That protein receptor becomes activated and it sends a signal to the inside of the cell, relaying a second signal to these GLUT receptors that upregulate. They come up on the surface of the cell, and once these GLUT receptors upregulate, then glucose can come into the cell. That's how that works. Every day, all the time, right now. What happens in people with type 2 diabetes is that the insulin receptor, I'm going to use red this time, I hope it works. The insulin receptor becomes resistant. In type 2 diabetes, which is in general brought on by obesity, a BMI higher than 30, in type 2 diabetes, the fat cells aren't just storing fat, they're also secreting hormones. And a hormone they secrete is called resistin. And this resistin hormone sits on the insulin receptor and blocks insulin from docking. So if it blocks insulin from docking, then you don't get this signal, and you don't get this signal, and you don't get GLUT receptors. So now what do we have floating around in excess in the vascular system? Glucose.
What do you mean by docking?
Docking, sitting on, connecting with. Yeah. So that's how you get hyperglycemia in type 2 diabetes. The pancreas is still working, but the insulin can't connect with its insulin receptors, so glucose can't get in the cells. So you have hyperglycemia. What does this have to do with health promotion? If we can detect this early and change lifestyle and get people to adhere to the lifestyle changes, then they can control their diabetes and they won't need oral or injectable medications. Yes.
That's when someone's overweight, pretty much creates
Yeah.
diabetes too. What happens if they lose weight and then they're still diabetes, they're still diabetic?
What happens is if we catch type 2 diabetes before the pancreas gets overwhelmed, like if this goes on for a long period of time, eventually the pancreatic beta cells will stop production of insulin, and now they become insulin dependent. But there are a lot of people that you can catch this before the pancreas gets sick. And if you reduce the amount of resistin, if you shrink the fat cells and reduce the amount of resistin, their pancreas takes over and everything's great. They don't need medication. Yeah.
I have a question. So then if you give them insulin, but these receptors are blocked, is the insulin affecting the pancreas instead? Or
So here's the good news. Aren't your cells constantly making mRNA? The mRNA is going to the ribosome and matching up with tRNA to make a protein. Mm-hmm. The cells are constantly making new proteins. So there will be eventually more insulin protein receptors upregulating on the surface of the cell. So then that insulin that's coming from the pancreas will attach to that and get the glucose in. But eventually the pancreas is going to wear out if you don't modify the lifestyle. Yes?
Is insulin considered then, when it attaches to the insulin receptor, is it considered a ligand then?
Yes. Anything that attaches to a protein cell receptor is a ligand.
Okay.
Medications are a ligand. Yeah. Hormones are a ligand. Neurotransmitters are a ligand. Yes. Yes, yes, yes.
For a number of years, I worked in a clinic in Southern Oregon, and we focused on diet training.
Yeah.
And we would get our patients' health to a point where they would go to their doctor, and their doctor would check their blood, and they're like, you don't need
You don't need medications anymore. Yeah. Did you guys all hear that? Maybe not. Over there. Your name starts with a B. Belinda, thank you. Belinda's saying that she worked in a clinic for a long period of time, and if patients adhered to their lifestyle modifications, diet and exercise are the two top ones, then they got their blood sugar under control, their pancreas survived, it didn't get damaged, and so the next time they came to see their provider, the doctor went, okay, you're in good shape now, you don't have to take medicines anymore. So does that give you a good picture of a real-world example of health promotion? We're going to be doing strategies to try to get people to adhere to healthy behaviors that will help them control and improve their health. I make it sound so simple. You guys tell me. Does it always work out perfectly that way?
No.
Okay, so what are the barriers to health promotion? Go ahead, list them. Because if you know what they are, then you can promote health among your humans. Yeah.
Maybe the patients don't actually follow the guidelines and just go back to their old ways.
Okay. Patients don't follow advice. Why don't they follow advice?
It's a drastic lifestyle change.
Okay, it is a drastic lifestyle change. According to your textbook, this is called perceived benefit. Do they perceive that if they change this diet and change their exercise patterns, do they perceive that that will result in a benefit that's worth it? Another thing associated with perceived benefit is the cost of action. Do you guys, this is, I'll just tell you, I forgot to put the page number there, but a lot of this is in your Hood textbook on page 191 and 192. Page 191 and 192. What? Oh, it's chapter, I don't know, the print's too tiny. It's chapter 8. Yeah, chapter 8. Yeah, like what's the cost of the action? I don't know. So, I don't know. Some of you know, some of you don't. I have ulcerative colitis. It's an autoimmune disorder. Causes ulcers in my colon. I'm in remission right now. One of the best ways to stay in remission and not need to take medication is through diet modification and stress and lifestyle modification. For diet modification, I'm supposed to avoid chocolate, nuts, spicy foods, and any type of alcohol. Well, that goes my Friday and Saturday night. So, right? It's like, what's the cost of the action? Do people slip every once in a while? Yeah, especially on bunco night. So, bunco is a lot of fun. Thank you. Yes. So those are some of the barriers that you're going to be dealing with, and how to get people back on track when they start to go down that slippery slope. Okay, why else don't people follow advice? Because not following advice is the big umbrella, but why aren't they following advice?
They think they know better.
Okay, they know better.
They don't trust the information coming.
Okay, trust. Boy, that's like, we've heard about that a lot today. Yeah. You know, and gaining that trust is so key. And it doesn't happen in a split second. It takes time. Yeah.
They might not have support from others around them.
Okay, people need social support. That's one of the resilience protective factors, is having good social support. Yeah, Sky.
I feel like a lot of people, they have their own autonomy and viewpoints, like they have their own morals and culture standards, and like they don't want to take a medication because it goes against their own beliefs.
Okay, so for some people, it could be what they value,
Yeah, that's the word.
what they believe. And there are certain groups, faith groups, religious groups, who don't believe in medications, right? They believe that they will be healed through prayer. Yeah. Okay, so that's a really good list of what are some of the barriers. So what are promoters then? What can we do to get people to listen, adhere, and control and improve health? What's a promoter? I'll give you an example and then we'll put some terminology to it. What if, you're my patient with type 2 diabetes, and I say to you, has anybody else in your family had diabetes when they got a little bit older? You say, yeah. And what if I say to you, so tell me about their lifestyle. How's their heart? How's their blood pressure? How's their feeling in their feet? Because people with uncontrolled diabetes get heart disease, hypertension, and neuropathies, peripheral neuropathies. They can't feel their lower extremities, which puts them at risk for diabetic foot ulcers and sometimes amputation.
So I know someone who was born with diabetes, and he can't feel any of his feet, so he has to wear socks all the time. And I don't really know if he regulates his diabetes that well, if I'm being honest. So do you think he developed that because he hadn't regulated it his whole life?
Yes, I do. So here's the thing, and I'll get right with you, Belinda. Here's the thing, uncontrolled hyperglycemia damages the arteries. It makes them stiff, which can lead to hypertension. It can also damage the arteries in your heart, which leads to cardiac risk for MI or heart failure. It also causes the nerve fibers in the distal ends, like your fingers and your toes, to degenerate and die, which causes the numbness. Starts with tingling and then numbness. And if they can't feel their feet and then they get injured, and if they don't inspect them, then they get diabetic foot ulcers. So that's neuropathy. They also get kidney disease, nephropathy, and they can also develop blindness, retinopathy. So that's why, I'm trying to get at how to promote health here. Paint the picture. This is where you're headed. This is where you're headed if we don't get this under control. Yeah.
So, to go on what you're saying is that when I used to work in dialysis, and so my primary client was somebody who was diabetic.
Yeah. Yep, they get nephropathy. Yeah. Yeah, so thank you, Brian. So what we want to do is inspire motivation. I'm not threatening them. I didn't come at the patient with a list of this and this and this and this and this are going to happen to you. Instead, you try to create the picture. Do you know anybody in your family or maybe at church or something like that who has this? And tell me, what's going on with them? Oh my gosh, they got black spots. They had to have their left big toe amputated. Oh, okay. So let's talk about how to make sure that doesn't happen to you. Unless you don't care, how important is your left big toe to you? You don't say that. I'm being silly now. But Belinda, you're going to say something. Same? Yeah, okay. So inspire motivation. According to your textbook, this is called trying to help people develop perceived seriousness. How serious do they think this condition is? And how serious could the complications become if they don't take care of it? And then also we have to inspire their perceived susceptibility. Susceptibility. How likely is it that they think they're at risk for all the complications of the disease? Or do they feel that's never going to happen to me? And if they feel that way, then how do we get them thinking that, wow, I really am susceptible and this really is serious. These are just some of the things. I would ask you to maybe go back to pages 191 and 192 in chapter 8 and take a look at that. But what I love about what we just did here is that you already knew this stuff. Now you're just putting the formal language to it. Yeah. When we're thinking about health promotion, I still want you to be thinking about all the components of a human being. So far, what have I only addressed in this whole conversation about diabetes? The physical stuff. And yet, I will have a better chance of getting them to adhere to what I'm talking about if I also blend in what's going on psychosocially, and can we tap in to the spiritual component here. And sometimes tapping into the spiritual component does mean praying with your patient. A lot of patients love it when you pray with them. Sometimes tapping into the spiritual component might look like this. So tell me, do you have a faith orientation? Why, yes, I go to church Y. Oh, you know what? I think church Y has a parish nurse or a community nurse. Maybe they could check in with you every so often and help check your blood sugar, or, offer that social support to keep you motivated. So do be thinking about the whole physical, mental, and spiritual aspect. So let's take a look at this kid using PMS. What do you see physically? Yeah, this child's overweight. What's this child trying to do? Play. So physically, they might be struggling to engage in activities, which is kind of making their weight a little bit worse. Because I don't know about you guys, but when I was a kid and tried to play sports, I wasn't that good at it, especially softball. It's horrible. Did people treat me kindly as a kid, or do you get made fun of? Sometimes you get made fun of. So physically, he's struggling to play. Mentally, does he want to get out and be active? If people are maybe going to treat him that way. So again, social support, good social groups, trying to nurture those. There are camps for kids with special needs, and not just mental special needs, but also physical special needs. There are camps that we can refer people to. And then spiritually. And when I say spiritual, I know I've been talking a lot about faith orientation. It's just kind of where I go to. The true definition of spiritual care is finding out what gives that person hope, peace, and meaning in life. So I'll back up and write that in here. The true definition of spiritual care is whatever gives that person hope, peace, and meaning in their life. So just even using those three things, we could ask that kid, what do you enjoy doing? What gives you, a kid's not going to understand, what gives you meaning in life? They'll understand, what do you enjoy doing? What gives you joy? What helps you connect with others? This child may have a faith orientation, but, may not. This is our health belief model that I just talked about. In the middle are the variables that we want to assess. Their perceived susceptibility, meaning, do they perceive that it's likely that they'll have complications? And then perceived severity. Do they perceive or understand how severe things could get, and do they believe it? That's severity. How motivated are they to change? And a lot of that motivation has a lot to do with these benefits of action or cues to action. Your book calls them benefits of action. but eventually we're asking people to do something. So are they motivated to do that thing, and do they have the resources to do that thing? Do they perceive that there will be benefits if they change behavior? And then we always have to be asking them, okay, what are the barriers getting in the way of the action? And then what can we as care managers do? What can we as care managers do to help decrease the barriers or help them figure out on their own, how do we decrease the barriers? These other things over here in the site are also really important. Socioeconomic class. Does that influence motivation and action? Sure, like what we're talking about here with socioeconomic socioeconomic classes, do they have the financial resources? Do they have insurance? Okay, we have time for this quick story. You guys, I don't know. This totally just happened. And I hate to think that God is letting bad things happen to my family members so you all can have a teachable moment, but it just seems to be falling out this way. My 23-year-old niece jumped over this thing a week ago, fell sideways on her foot, and popped her bone right out her skin. She's on the Oregon Health Plan. What's the Oregon Health Plan? Yeah, it's Oregon Medicaid. Yeah, it's Oregon Medicaid. She doesn't have a job, not a lot of financial resources. So she's on the Oregon Health Plan. This happened in Vancouver, Washington. So the ambulance brought her to Peace Health. And they had to do emergency surgery because she nicked an artery down there when the bone popped out. So the orthopedic surgeon took care of her there. She comes home. Yesterday she calls me. Aunt Loretta, I need help. The orthopedic surgeon in Washington, I can't go see that person because they're not on Oregon Health Plan. They're not an Oregon Health Plan provider. Oregon Health Plan told me to go see this orthopedic surgeon up by St. Vincent's. I showed up to my appointment because she has to get the stitches out and the cast off. She goes, I showed up to my appointment and they said, oh, I'm sorry, we should have called you ahead of time. We refused to see you because our surgeon didn't do your surgery. She's like, what am I supposed to do? Because then she called the guy back in Vancouver again and he goes, I'm not taking you. You're on Oregon Health Plan. I won't get paid. And I'm like, okay, we need a care manager. I know that Oregon Health Plan has care managers. I'm like, we got to get a care manager involved here to tell the orthopedic surgeon up by St. V's he's required to see you. You're a human being with rights. You're insured. She's like, I wish you were there with me. So anyway, why do I talk about this? Does socioeconomic class influence health? Yeah, I mean, like she's getting the runaround, this poor little 23-year-old. We're still working it out. Yeah. Gender could play a role in somebody's health belief patterns. Are you guys wondering how? Oh my gosh, please, men in the room, this is not my research. Somebody else did research and shared it with the nursing world. This will show up, you'll see it. It especially shows up when it comes to traumatic injuries. The research and data collection shows that men are a certain percent more likely to be involved in a traumatic injury because of high-risk behaviors. I think it's for other reasons as well. So anyway, so that's why gender matters. They also said in their study that men are more likely to fall in the hospital because they're less likely to ask for directions or help. So take that with a grain of salt. I think that's oversimplified, but yeah, that's one reason why that shows up here. We could also say things about women too, I'm sure. Yeah. Age matters for sure. A little kid, they're at the mercy of whoever their guardian is to take care of them and get them nutritious food, right? So that's how the demographic variables play in. And then the psychological characteristics. This says personality, peer groups, pressure. We kind of talked about that with that kid, didn't we? Maybe that he's experiencing some mocking or belittling. So he needs a better group. The health belief model can also be applied to you as nurses and the work-related stress that you're going to experience. That work-related stress is already happening because I read all 53 of your pre-class assignments this week. And if you treat nursing school like a job, you've already got some work-related stressors going on, is what I read. So when you're writing your self-care action plan, do be thinking about physical, mental, and spiritual strategies that you could implement to promote resilience. Resilience is the capacity to keep going and overcome adversity. I handed out that resilience protective factors score card or survey. Some of you got a chance to do it, some of you didn't. I would encourage each of you to do it. It's just like any survey, it's a snapshot in time, but it may highlight for you some areas of strengths that you can try to get more of. What are the resilience protective factors? In a nutshell, these resilience protective factors that help us keep going even amidst adversity include social support. Social support can be family, friends, classmates, professors, teaching assistants, ministers, whoever is your social support person. God made us in such a way that we find hope and meaning with each other. Has anybody watched the miniseries called Alone on the History Channel, where they put somebody out alone on an island?
Yeah.
What really does them in is the isolation. It's the mental isolation. That should be a good homework assignment. It's a really good show. Yeah. The starvation doesn't do them in. Injuries do a couple of them in. One guy like hacks his foot or something. Yeah. I think that's season 4. Yeah. Yeah. But at any rate, we are designed to be in community with. So social support is super important. Another protective factor is goal efficacy. Goal efficacy is your belief that you can set a goal, set priorities, and achieve it. Do you believe that? As I was reading your pre-class assignments, some of you talked about the Hood textbook, talking about affirmations. Like, you need to be giving yourselves positive affirmations. Yeah, we all have something icky go on during the day, but what went well? What did go well today? That will support your self-perception that you can set a goal and effectively achieve that goal. Social skills is another resilience protective factor. Social skills primarily means that you know how to get along in a group. Even if you're shy, you at least, attempt to reach out and communicate with people. That you take leadership when you need to take leadership, and you're also a servant when you need to be a servant, and you're a follower when you need to be a follower, and you have so many other roles, but you do those roles within a social setting. Those are social skills. And then the last one, you're going to love this one because a lot of you talked about this. Planning and prioritizing behaviors. This is the capacity to look at what you need to do, prioritize those in order of how you need to do them, and then sit down and schedule it out and make it happen. And a lot of you talked about time management. So the resilience protective factor for time management is planning and prioritizing behaviors. I would also say maybe some social support. Maybe our time could be managed more effectively if we had somebody supporting us in that way. These 4 categories of resilience protective factors will help overcome the balance of the risk factors. So what did we identify? This isn't on your slides. It's not going to be tested. It's just for fun. I took a look at what you all said and wrote them down here for you. This is percents, by the way, because remember I asked each of you to list 3 stressors in college, so it's a percent of the whole. So the majority of you said that your biggest stressor in college is trying to find balance. That was like almost 58% of you mentioned that one. And when people were talking about that, they're talking about balance between school obligations, work obligations, family obligations, and oh yeah, I like to have some fun sometimes, having a social life. So what resilience protective factors would we use there? Social support is a good one, yes. Planning and prioritizing. Actually, goal efficacy. Yeah, they all kind of fit there. Time management was the second most reported stressor. So again, our planning and prioritizing. Grades. I do want to talk about this, and we have time. I heard and read a lot of what you said about having to be so competitive with your grades in order to get into nursing school. I feel ya. I had the same thing in Montana. I was a transfer student into my program, and they went off of GPA in order to decide who got admitted. So here's what I'd like to do right now. Stretch out your arm to the person next to you. Shoulders are considered least intimate and least invasive, so maybe just stretch out your arm and put it on your classmate's shoulder. And repeat after me. Oh, you need a shoulder to hang on to. Can you reach? Okay. I am a nursing student at George Fox. And I am here because God planned for me to be here. I made it. And I'm going to make it. That is adorable. Yeah. I don't know, I'm making this up as I go. You are not my competitor. You are my classmate. And we will support each other.
Come on, like that's true.
Amen. I just got chills. You guys are awesome. You guys are awesome. Okay. It's so true. You'll achieve so much more together than you will alone. So true. Okay. Financial. That was the next one. Let's move on because I have no answers for that. You guys, I know it's a stressor. My husband and I paid for my schooling, and a lot of you are doing that as well. We do have a financial aid office. I don't know much more about it than that. Belinda. No, Jolene. Sorry, I got people confused. Anybody who has kids, there is a scholarship out there to help pay for childcare that our dean didn't know about when I told her.
It's a need-based one.
Okay. What's it called again?
It's through OSAC.
So anybody who has children, there is a scholarship out there to help pay for childcare. You have to apply. Yeah. But that would definitely decrease the burden. And if the award period is passed, it's annual. Yeah, beautiful. Anyway, yeah, there are resources out there. Test taking, yes, that's a stressor, no doubt about that. You do have a module on your course page. It's in this course, your Wednesday course. It's near the top of the course page somewhere, and it's called Nurse Tim Student Success Modules. If you click on that, it will take you to the Nurse Tim website for students, and there is a module on test taking strategies in nursing. See if you like that. It's on our Canvas course page near the, oh wait, if you found it, here, I'll just take a picture real quick so it's on here and everybody else can see it. Boop, 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 boop. You found it. Oh, no, that's not it.
Yeah,
Oh, there it
right
is. Okay. I'm sorry. I can't run my own machine. It's right there.
Mm-hmm. It's highlighted there.
There we go. Boop. There we go. Student Success Nurse 10 modules. If you click on that, it will take you to a bunch of modules. It's going to just look like a white screen, but just click in the middle of the white screen. It'll show up. There's, what's that?
Oh, student resources.
Yeah, student resources. So that's a resource for you guys. And then being away from home, yeah, that showed up about 15% of the responses. And so hopefully we can be family for each other, for those people who are feeling like their social support system is not what it used to be. Okay. Now, your self-care assignment. So health promotion. I think we got the gist of that. There's a health belief model. It involves motivators, barriers. We talked about resilience, how to promote resilience, what are the 4 categories, how to help each other. On your self-care action plan assignment, what you're going to do is download this document that's on the assignment link. I suggest you just download it. It's a Word document. It's not a PDF. It's a Word, and it's fillable. So I would have that available. And then also click on the next link that is the instructions. And what you're going to do is fill this out. I do have to give some really clear instruction about what you're going to put in this assessment column because it always causes confusion. In the assessment column, you are doing a self-assessment. Subjective data is non-verifiable. Verifiable. It is what if we're talking about a patient, it's what the patient reports or what the patient says. Okay? I'll give you an example here in a second. Objective data is what the nurse, it is verifiable, it's verifiable, and it's what the nurse sees, hears, smells, and any kind of data that you collect, like vital signs, lung sounds, bowel sounds, those kinds of things. It's your assessment data of the patient. So I'm going to give you an example here, and I want you to tell me what's subjective and what's objective. I don't have any pain. My pain's a 0. On a scale of 0 to 10, 0 is no pain, 10 is the worst pain. What is subjective? Me saying my pain is 0. It's just what the patient says, and we document what they say. What did you notice about my pain objectively? Was I whining or crying? And I was limping? That's what you document objectively. What the patient says is subjective. Does that make sense? Now you have to do this on yourself, and students usually email me and say, who am I filling this out for? And I'm like, on yourself. So, like, let's say that the stressor, you're going to choose one of the stressors from your pre-class assignment and finish this assignment on just that one stressor. So let's say the stressor is lack of sleep. Subjective. You're talking about yourself now. So feel comfortable saying, I report. I report. I am tired. Now, when you do this on a real human and clinical, you'll say patient reports or patient states. I report I am tired. I only sleep, somebody give me a number. 6 hours per night. That's all subjective. I am not watching you sleep for 6 hours a night, so I have to rely on your report. That's subjective data. It would be objective data if I sat there and watched you, which I do to my grandbaby on the camera. She's so cute. Okay. So then what is objective data? You're going to have to like put yourself in the frame of an external person looking at you. So maybe objective data is
Yawning.
okay. We see them yawning frequently.
Sweaty palms. Sweaty palms.
Sweaty palms. Patient is behaving agitated or cranky. What's that?
Did they have a log or something, like a sleeping log?
If the patient uses like their Fitbit or they have a sleeping log, like if you wear your Fitbit all night, it logs on your iPhone, your sleep cycle. If you actually observe that, that's documentable. So sleep log indicates 4 hours per night, whatever, something like that. That's what you put in under the objective stuff. And then the rest of the instructions that I give you on my video will fill all that in. Sound good? Okay. Yeah, it's going to go great. It's worth like 5% of your grades, so I give you a lot of instructions to make that go great. Just like our patho class, I finally got around to inserting for your review questions here. Use these as a study guide for your first exam. And then as you exit today, think about who you are and who you're becoming. Do you know more about nursing today than you did August 30th?
Yes.
Okay. All right. Thanks, guys. Bye.